Our next chapter involves the diseases of the adrenal glands, and we're going to start off with hyperfunctioning of the adrenal glands, and we're going to be talking about Cushing's syndrome. The Cushing's syndrome is a very interesting disease, and we could all remember the typical presentation that we see with Cushing's syndrome, the acne, the buffalo hump, the moon faces, the purple striae, the truncal obesity, and then they develop hyperglycemia. This is important, finding hyperglycemia because the corticosteroids are counter-regulatory hormones, so about 20% of these patients have frank diabetes, and they also develop hypertension in a good percent of the population because the corticosteroids, again, cortisol has mineralocorticoid action. It's not potent mineralocorticoid action, but it has some, and these patients develop hypertension. Patients that have Cushing's syndrome for a long time, they develop osteoporosis. Right, this is typical of patients either taking steroids or they develop Cushing's syndrome, that they develop osteoporosis, especially when this occurs over a period of time. These typical features, right here, these are all the typical features of Cushing's syndrome, and if you take away the iatrogenic Cushingoid features that people get if we give them steroids. For example, people that you treat for lupus, with steroids for a long time, or people that have steroid-dependent asthma and been taking steroids for a long time. These, if you take away those, this typical presentation only occurs with this thing called Cushing's disease, which is the pituitary form of Cushing's syndrome. So that's the typical disease that causes the typical presentation of Cushing's syndrome, and that was the disease that Harvey Cushing described almost 100 years ago at Johns Hopkins when he presented a case of a pituitary adenoma that had a buffalo hump, moon faces, the striae, all the typical features of Cushing's syndrome, and this is referred to as Cushing's disease, the pituitary form. The pituitary form is the one that's long-standing. It occurs for a long time. That's why you develop the typical features. Some of the other Cushing syndrome, and we're going to talk about it just in a little bit, don't have the typical features. You don't get the buffalo hump because they're short-lived syndrome. So for example, a patient having a lung cancer who develops lung cancer, oat cell cancer, and they secrete ACTH, a paraneoplastic syndrome occurs, Cushingoid features that these patients develop a Cushing syndrome. I shouldn't say Cushingoid features. They develop a Cushing syndrome. They don't have the typical presentation of the acne, the buffalo hump, the moon faces. The reason is because these people lose weight, they have cancer, they seem wasted, they don't have the typical features. So the typical features occurs only with iatrogenic forms of Cushing's syndrome or Cushing's disease, the pituitary form of Cushing's syndrome. Now, so I want to give you a little bit of an overview and talk about these different types because they're important for the boards. Now, the most important one, and is that we see clinically is iatrogenic or exogenous Cushing syndrome. And you usually know about this because the patient says, yeah, I've been taking 20 milligrams of prednisone for steroid-induced asthma for the last 15 years or so. So that's usually known. It's not something that it's hidden in the history. And this by far is the most common form that we see of Cushing's, the iatrogenic, the exogenous form when the patient's taking oral prednisone for years and so forth. The endogenous form, which is the endogenous form of Cushing syndrome, right here, the most common form is Cushing's disease, right here, Cushing's disease. That's the most common form of endogenous Cushing syndrome, and really when we talk about Cushing syndrome, we're really referring only to the endogenous form because the exogenous referred to as Cushingoid syndrome. So Cushing syndrome, the endogenous form, Cushing's disease, the pituitary disease is the most common form of this syndrome, and then after this, it's adrenal neoplasia, and then after this, it's lung cancer, the other forms. But I want you to remember kind of as a stepwise way to remember the etiology, because when you work up the patient, that's the way you have to remember the etiology and the differential diagnosis. So when you start up high, the first cause is pituitary adenoma in the pituitary. Then you go into the lung, where you have lung cancer producing ACTH. This is small cell cancer. And then further down into the adrenals, where you have some kind of adrenal neoplasia or adrenal hyperplasia or something like that. But now you have cortisol production. Remember, with the pituitary form and the lung form, you have ACTH production. With the adrenal form, you have more of a cortisol production, and the ACTH in these patients is suppressed. It's downregulated because of the high production of cortisol. So Cushing's disease, the most common form, and lung cancer, a paraneoplastic syndrome, are ACTH dependent. They produce ACTH to basically upregulate the adrenals, to produce cortisol, to develop Cushingoid syndrome, and then adrenal neoplasia or adrenal hyperplasia of any form, any adrenal lesion. In these cases, you have cortisol production by the adrenal, and now the ACTH production is downregulated and inhibited. So let's say you have a patient that you're considering has the clinical suspicion of Cushing syndrome, some form. You've excluded the iatrogenic form, so you think this patient has some form of endogenous Cushing syndrome. So they have some kind of osteoporosis, or they have the truncal obesity, or the purple striae, and so forth. And then you decide that you have to answer the question, does this patient have Cushing syndrome? And the first test to do is this easy screening test, and this is called the overnight dexamethasone suppression test. Now this is easy because you could give this patient the dexamethasone. The dexamethasone is a potent cortisol derivative, right? And you give it to them overnight. They take it in the middle of the night, and then they come in the morning and you measure cortisol in the morning. Now, think about that. If you give them dexamethasone, a potent steroid derivative, overnight, a patient that's normal, you should suppress the ACTH cortisol axis in the morning. So a normal patient, once you give them dexamethasone overnight, you should measure cortisol in the morning. If they don't have any Cushing syndrome, their cortisol level should be suppressed. So here it is. Look at this. You gave this patient overnight dexamethasone, right? And if it's normal, right, which is suppressed right here, suppressed, then you stop. This patient doesn't have any Cushing's, because you proved that you could suppress this cortisol. And you can't do that with any forms of Cushing. So the overnight dexamethasone is a good early test to do to say to exclude Cushing's. It's only used to exclude, because if this test is abnormal right here, if this test is abnormal at this place right here, now look at this. Although it's a good test to rule out Cushing's, an abnormal test can occur in obese people, it could occur in depressed people, it can occur in anxious people, so it has a lot of false positives. So it's used to rule out the disease, but if it's positive, then we have to go to one step further, and we have to do the gold standard test, which is the 24-hour free cortisol. This is the gold standard test. Whatever this says, this is it. Now some books will tell you to go to this test right away, the 24-hour free cortisol. And yes, the answer is, if they give us one test to do, then forget about the overnight dexamethasone suppression test and just go to the 24-hour free cortisol, because that's the gold standard test. Why some people don't do it right away and they use it as a second test is because it's labor intensive. This patient has to collect 24 hours of free cortisol. You have to give them a special jug. They have to send it back. They have to send it to a specific lab. It costs a couple $100 to run this test. So it's a more expensive test, but yes, it's the single best test to do to diagnose or exclude Cushing's syndrome, all forms of it. Because the overnight dexamethasone has a lot of false positives, this is the gold standard test, but I wanted you to know the overnight dexamethasone suppression test because it's still in some of the questions that we use. If they give you both of these tests, then you're going to go straight to the 24-hour free cortisol. That's the bottom line, because that's the gold standard test. Whatever this test says, that's the bottom line. If it says that the 24-hour urine-free cortisol is normal, no Cushing's. You could stop right there. This patient may look like Cushing's, but they don't have Cushing's. If it's an abnormal test, you have Cushing's syndrome. Cushing's syndrome. Now the question is, where is it? Where could it be? And you know where it could be. It could be in the pituitary, in the lung, or the adrenals. You have to localize it now. So to recap this part of the workup, there's only 2 tests that you could do to answer the question, does this patient have Cushing's? The overnight dexamethasone, which is a good screening test sometimes, a good first test, but the gold standard test is the 24-hour free cortisol. Some people do only 1 test and they go straight to the gold standard test. So it's okay to do that as long as you know both of these tests and how to use them. Now, we're right here. We got a patient that looks like they had Cushing's, and we did a 24-hour free cortisol, and they have an elevated 24-hour free cortisol. So they got Cushing's syndrome, right? So what do we do now? Well, we know some differences. One difference between these 3 different diseases is that some of them have elevated ACTH levels, right? That's the lung cancer and the pituitary lesion. And the adrenal has low ACTH levels. And then the other big difference is that the pituitary adenoma, also called Cushing's disease, is a more benign disease. It's more suppressible. People say it occurs for 10 to 12 years before the diagnosis is made because it's such a slow disease. It's not like the other diseases like the lung cancer and the adrenal lesions where these are more aggressive diseases. So it's a more benign disease, and if you increase the amount of cortisol that you give this patient, if you increase the amount of dexamethasone, I should say, which is a cortisol derivative, you could suppress the pituitary lesion because it's more benign. It's less aggressive, more benign, and you could suppress it. And that's the other difference. So those are the 2 differences, and look what we do. We base the rest of our workup in localizing the lesions in these differences. So look at this. The first thing we do is we give now the high-dose dexamethasone suppression test. Now I increase the amount of dexamethasone from 1 milligram to 8 milligrams because I say to myself, okay, I know one of these types of lesions I could suppress if I increase the dose because it's a more benign disease. The other ones are aggressive and nothing is going to happen. So look at this. I give the guy the overnight dexamethasone, the high dose dexamethasone suppression test, and if I suppress it, forget about the 50% control here, just say suppress it, suppress cortisol in the morning, then the answer is it could only be one thing, pituitary adenoma. Pituitary adenoma, this patient has Cushing's disease because that's the only one that's suppressible with the high-dose dexamethasone suppression test. And what do I do right here is I localize it. What's the best way to localize the pituitary is do an MRI of the pituitary right here to localize it, and then I send this patient to the surgeon, and it's a very, very treatable disease. So everybody's happy in the end with this disease. On the other side of the coin though, what if I give the overnight dexamethasone suppression test and now there's no response? So now I say to myself, okay, I got one of 2 things. I either got lung cancer, it says here ACTH producing tumor, right there, lung cancer, that's the most common one, or adrenal neoplasia. Do you know any difference between the 2? Yes. I know that one has a high ACTH level and the other one is low. So I'll measure ACTH here. If it's low, I have adrenal neoplasia. And what do I do now? I get an MRI or a CAT scan of the adrenals to look at that. You don't have to know all this stuff here. the urinary 17 KS and DHCA and stuff like that. You don't have to know that. All you have to know is that if the ACTH level is low here, we have adrenal neoplasia, and do an imaging study of the adrenals with an abdominal CAT scan or an MRI to localize the lesion and find it there. If the ACTH level is high, right here now, then you only got one thing, and that's lung cancer. And then we do a CAT scan of the chest to localize the lung cancer. Unfortunately, most of the times this is unresectable, untreatable disease. Now, they may also ask one more question about Cushing's syndrome on the boards, and that is, they may ask you, are these two patients clinically different? And the answer is yes, because these patients here, right here, with lung cancer have elevated ACTH levels, they have hyperpigmentation. In fact, they have a lot of hyperpigmentation because lung cancer secretes a lot of ACTH. So these patients develop hyperpigmentation that's significant. You could see it clinically, versus these people with adrenal neoplasia here, where they don't have any hyperpigmentation. Now, people with Cushing's disease also have hyperpigmentation right here, but it's less significant. It's usually more profound with the lung cancer because the lung cancer is very aggressive and produces high amounts of ACTH. And remember, it's the ACTH that causes the hyperpigmentation because it's co-secreted with melanocyte stimulating hormone. In fact, they look exactly the same. There's only a couple amino acids difference, and that's what causes the hyperpigmentation. It's a factor of ACTH. Now, so I'm going to recap here and just tell you, please know this. They could ask us one question, and they'll go down here and asking us different tests, and they're positive or negative, and then they tell you in the end, well, what is this patient likely, what type of Cushing syndrome does he or she likely to have? So we have to know the two tests that tell us the diagnosis of Cushing right here, the overnight dexamethasone suppression test, and the 24-hour free cortisol. The 24-hour free cortisol is the gold standard. And then once we have an answer from that we do have Cushing's, then we really do only two tests to localize the disease. And that's the overnight high-dose dexamethasone suppression test and the ACTH, nothing else. So really two tests to diagnose the disease, and then two tests to localize the disease and tell us which of the three syndromes we have. So we have to know about that. So a little bit further down, we want to talk about the diseases of the aldosterone axis, and I want to tell you a little bit about